tumors of the liver. We'll discuss the other variants and also the surgical and other treatment for hepatocellular carcinoma. Over to you, Ainas.
Yes, sir. Uh, so, for to complete, we had seen till the manage. Earlier we had stopped till the staging and available strategies for hepatocellular carcinoma. Now, to complete the one more variant of hepatocellular carcinoma includes fibrolamellar carcinoma, and it was originally called as eosinophilic hepatoma with associated lamellar fibrosis. It is a very rare tumor, and it is accountable for less than 1% of all the primary liver tumors, and of the primary liver tumors. Epidemiologically, if the difference between
Einass, one
FLC.
second. Sir, Swaroop
Yes,
sir
sir.
has joined, sir.
Good. Thank you. Swaroop, good evening. Thank you very much. I tried to
Sir,
call
good evening.
you.
Actually, I'm in another meeting also,
Ah,
physical meeting. So I'm just listening, sir.
okay. Right.
Yes, sir.
Okay.
See, I was informed only half an hour earlier in
I
this
know.
physical meeting is also there, sir.
I've chastised the Ainas suitably for it.
All
You
right,
should
sir.
be
Sir,
given enough time. Okay.
yes, sir. Yes, sir.
Sorry for the
No
inconvenience.
problem, sir. I'll be less active, but I'll be listening, sir.
Yeah.
Yes, sir.
And we want your opinions in certain ways.
I'll
You
be
can,
listening, sir.
yeah.
I will
You can
chip in
just
when you ask me.
interject and please let us know.
Yes, yes,
Okay.
sir. Yes, sir.
Thank you.
Yes, sir.
Start, Ainas.
Yes, sir. FLC is differs from hepatocellular carcinoma in certain ways. It is known to affect younger individuals between the age group of 5 to 35 years. And there are two peak incidents which are seen, one from the age of 10 to 30 years, and another which is between the age of 70 to 79 years. However, in the average age of diagnosis is around 39 years, and in contrast to the conventional hepatocellular carcinoma, there is no male preponderance seen, and the data supports that there is equivalent incidence which is seen in both genders. Going to the etiology and pathogenesis, there is the exact etiology and pathogenesis is unknown. However, FLC tumor cells have markers of both hepatocytes and biliary differentiation, and there is some evidence which suggests that hepatitis B virus infection is an etiological agent, and it can predispose to development of this variant. Further, that follicular nodular hyperplasia is also considered to be a precursor lesions in some cases. However, there's not a lot of evidence to support this. But, in terms of genetic predisposition, there is a recurrent fusion gene between DNA JB1 gene and protein kinase alpha gene, that is PRK ACA gene. This has been reportedly seen in majority of the FLC with cases which have been studied, and this pathogenic, this fusion transcription is associated with the development of FLC. Uh, Further, going to the clinical features, the clinical features of the fibrolamellar variant are usually non-specific, and they can be associated with nausea, abdominal discomfort or fullness, weight loss, and or night sweats. And some patients can also present with symptoms related to metastatic disease, and rarely patients will present with symptoms related to tumoral hormone production. That could be gynecomastia, which could be because of aromatization of androgens, or there can also be an associated paraneoplastic production of thyroid hormones or beta HCG. Further, hypoglycemia can also be seen. This is related to utilization of glucose by the tumor, and also hyperammonemia, which is because of an acquired ornithine transcarbamylase deficiency, which will attribute to the development of elevated levels of ammonia. Going to the diagnosis, the imaging on cross-sectional imaging, the CT will on CT scans, FLC will mostly appear as a large, sharply defined, heterogeneously enhancing mass in a non-cirrhotic liver, and a characteristic feature of a central scar or calcification may be present. Occasionally, FLC can also present with multiple intrahepatic lesions, and they might have a cystic appearance on CT. Furthermore, MRI can, again, similar to what we had seen in HCC, MRI can be used, and the central scar is hypointense in appearance on both T1 and T2 imaging, and T1 and T2 imaging, and the distinguishing factor is that if a person has focal nodular hyperplasia, there will be an hyperintense scar, whereas in FLC, there is a hypointense scar which is seen, the central scar present. And further, going to tumor markers, one significant finding here is that AFP has very little role in diagnosing and monitoring the disease progression associated with FLC. There are only 7 to 11% of patients who can come and present with an elevated serum AFP level. Some tumor markers like the des gamma carboxyprothrombin, vitamin B12 binding capacity, and haptocorin and neurotensin as well. These tumor markers may be associated with FLC, and they can show an elevated level. On histology,
Einass, 1 second.
Yes,
Sir, Rajesh Ballal sir has joined.
Yes,
Good
ma'am.
evening,
Yes.
good evening, sir.
Good evening, sir. No problem. I just wanted to join, sir.
We are discussing the second class of
I know. I missed everything, sir. Yes, please go on.
hepatocellular carcinoma. Okay,
Yes.
thank you.
Further,
Histology.
Yes, sir. On histology, pathology, usually this is the gold standard for establishing the diagnosis. Grossly, it is going to be appear as a solitary, large, firm, and well-circumscribed tumor, which can be encapsulated. And the cut surface will demonstrate fibrous bands, which will divide the tumor into smaller nodules and give it a resembling appearance to that of focal nodular hyperplasia. And microscopic evaluation here will reveal well-differentiated polygonal tumor cells with eosinophilic cytoplasmic bodies. So here we can see that the characteristic appearance on there are large polygonal cells which are filed with eosinophilic cytoplasmic bodies. The arrow which is present is showing the cytoplasmic body, and there is adjacent parallel arrangement of the fibrous stroma, which is shown only by the small arrowheads which are present. So histology is one of the gold standards for establishing the diagnosis. Furthermore, there is molecular diagnosis, although which is not frequently done, but as mentioned before, that the DNA JB protein kinase A fusion is detected in all FLC, but this is not very specific. And sometimes there can be a unique deletion of chromosome 19, which will result in the fusion of these genes, which can be detected. And this can be detected by RNA in situ hybridization, RT-PCR reaction, or the fluorescent in situ hybridization method. And furthermore, the differential diagnosis in FLC can be that of it mimicking a benign liver mass, such as adenoma or focal nodular hyperplasia. It can also be associated with it can also mimic hemangioma, mesenchymal hematoma, and other malignant lesions like hepatoblastoma or fibrotic metastatic tumors such as that seen in breast cancer, carcinoid or islet cell tumors, and cholangiocarcinoma. So going to the management, the there are various treatment modalities which are available, which can be divided into surgical resection, locoregional therapy, ablative therapy, and systemic therapy. Firstly, going to the surgical resection. Um, Firstly, going to surgical resection. Herein, first we'll be seeing how to choose the candidates which are eligible for surgical resection, the preoperative assessment, and the hepatic reserve volumetry, and further the clinical scoring which will be seen. In terms of choosing the candidates, patient suitable for candidates are usually confined to those lesions who have in cases where there is a HCC without invasion of the vasculature of the liver, preserved hepatic function, and no evidence of portal hypertension. The main potential resectability of HCC basically focuses on these two, that the disease is being confined to the liver, and also one of the major point is that the size and the location of the tumor or the extent of liver resection is relative to the patient's underlying liver function permits the resection without any excess morbidity or mortality. Per se, stage 3B, 4A, and 4B disease are considered to be incurable by resection. These stages are usually defined by invasion of a major portal or hepatic vein, direct invasion of organs other than gallbladder, or perforation of the visceral peritoneum. This will come in stage 3B. Nodal or distant metastasis, which will be included in stage 4A and stage 4B. Further, extrahepatic metastasis, wherein the recognized sites of metastatic spread include lung, bone, peritoneum, and adrenals. These should be excluded. And usually, if the tumor size is larger than 5 centimeter, it is more located at a subdiaphragmatic location, and with a marked elevated alpha fetoprotein levels. These are at a risk of extrahepatic metastatic disease. And furthermore, you should also look for symptoms such as that of bone pains, which will be an indication towards extrahepatic metastasis. Portal lymph node.
Einass,
Yes, sir.
wait. Are you talking about hepatocellular carcinomas in general, or are you talking about fibrolamellar variety?
No, sir. Hepatocellular carcinoma in general, sir.
Okay.
Yes, sir.
Which means, can I interrupt for a minute?
Yes, sir.
Yes, sir.
That was what I was confused also, because in the previous slide you said that histology is the gold standard.
Yes, sir. No,
You
sir.
spoke of diagnosis and you said imaging, histology, and moleculars, right?
Yes, sir.
And you said histology is the gold standard. Two questions in that. Do you need always? Is it possible always? HCC, I'm not talking of FLC.
No, sir. For HCC, we don't always need this. Biopsies are not indicated in HCC always, sir. Liver biopsy.
I don't know your source. You mentioned the source. I didn't know where that was. You said histology is gold standard. Sometimes I think it is difficult.
So in FLC will be for diagnosing FLC.
That's why I'm asking.
But not
That's
for
why
HCC.
sir said FLC or HCC. I'm talking about HCC.
That was FLC, so HCC
fine,
I had completed in the earlier class.
Fine.
So
I'm sorry.
this was only
sorry.
for
Yes.
Yes, sir.
Sorry,
Yes,
sir.
So now other thing is the surgery. You are now talking about surgical resection. I think first we have to talk about resectional treatment, and then second there is transplant. In transplant, there are many criteria in terms of hepatocellular carcinoma, which are amenable for transplantation. So I think the most important criteria is the Milan criteria. Then there are so many University of California, San Francisco criteria, and then there is the Guangzhou criteria. Then there is the Canadian Edmonton or something criteria. I think because Rajesh Ballal sir said about histology, Only the Canadian one will rely on the histology before considering the transplantation, the grades and all that. The Milan criteria is obviously the most rigid of them. And now we'll talk about the surgical resection, because transplantation will be the next class. You can touch upon the indications for transplantation, and there you can talk about all the criteria for the when hepatocellular carcinoma becomes an indication for liver transplantation. So now let us just talk about the resectional treatment for hepatocellular carcinoma. Okay, continue, ma.
Yes, sir. Furthermore, there is a exclusion of portal lymph node, metastasis should be excluded. Regional nodal involvement is although it is very difficult to assess it, because preoperatively to detect nodal metastasis is limited because of the frequent presence of benign nodal enlargement, which is often present, which is involving the porta hepatis and the porta caval spaces.
How do
Further,
you overcome that problem, ma? Anybody? Let us ask somebody else, and then we'll come back to einass. Samir, just think, how can you, she said, I think it's a very good point. See, the hepatocellular carcinoma, as we already in the last class, talked about, the PET CT is not a good method of evaluation of hepatocellular carcinoma. We rely on the, three-phasic CT, and then we rely on the MR. So those are the two important investigations, and for, to give you the stage of the disease. So the involvement of the lymph nodes, they may be enlarged. There may not be specific features to suggest that they are malignant. So how do you overcome the problem of one staging and doing unnecessary surgeries? So if Samir doesn't know, we'll go to Nikita and Praveen.
Sir, can we do only lymph nodal resection, sir?
How can you do only lymph node dissection? Praveen? Vinod? Come on, man, think it's not that difficult. Nitya and Sanya, in that order.
We take it as not access, something like N0, sir, and we'll proceed.
How can you presume, man? You, for example, lymph nodal metastasis will obviously alter the prognosis and overall survival and disease-free survival, right?
Yes, sir.
Then how can you presume that it is not involved? See, if there some of the size and all these things, which will obviously tell you that it may be metastatic. But some of the lymph nodes which they describe may not be truly metastatic. As I think einass said, some of them may be just enlarged inflammation or whatever it is. Tanya and Nitya. It's not that difficult. But do a diagnostic laparoscopy. Look at the porta area. See if there are do a you see look at the lymph nodes and send it for frozen section. So frozen section is a good friend for you. While you are doing the resection, you can send the lymph nodes for frozen section. If, for example, lymph nodes beyond the area of resection is involved, then you may have to cut your losses and then consider whether you want to do a liver resection, or then consider other ablative forms of treatment, because liver resection can be, especially in patients who have background cirrhosis. If you are removing a significant amount of gland and there is cirrhosis already, then the residual liver volume may be very low. So, and then those people may have hepatocellular failure and die. So you have to be extremely careful. You can't take liver resections easily, so you may have to do frozen section of the nodes, and then if the nodes are not involved, then go ahead with the resectional treatment. Rajesh, sir?
I'm listening.
Sir, your views.
No, nothing. No, sir. No views on that. I had only one question about portal vein embolization as to the principle of it, sir.
Yeah.
How does it
So,
work? I wanted to know.
Einass, are you going to tell us about portal vein embolization?
Yes, sir. I am, sir.
What is the principle of portal vein embolization?
So basically, you do preoperative portal vein embolization. So you are electively obliterating the portal blood flow to
Ah.
a selected portion of the liver a few
Ah.
weeks prior to what you have planned, like to a few weeks prior to the major liver resection. And
What
you are
happens?
doing this is because there will be a hypertrophic physiological response in the non-embolized position, sir. And because of this, you are augmenting the volume and the function of the future liver remnant, sir.
Very good.
So as
That's
to
Point taken.
uh,
Yes.
What is that called? Hypertrophy atrophy complex. So
yes, sir. Yes, sir.
the segment that has been embolized containing the tumor will atrophy, and there is compensatory hypertrophy of the other segments. So as you said, one, there is functional reserve will also increase, and then possibly the vascularity of the tumor will also increase, giving you better chance of resection and also minimizing the blood loss during surgery.
Yes,
Rajesh
sir.
sir, anything
Yes,
to
sir.
add?
No, sir. No, sir. No, because if you look at the history, hepatic artery ligation was a big method, no, sir, to treat.
Yeah,
That's
correct.
gone out of the window now, with thanks
Correct.
to other newer things.
So what are the other things you can do, ma? Can you do TACE before surgery?
Yes, sir. You also consider like plus minus taste can be done, sir, because basically you are reducing the tumor blood supply, and in addition, if there are any arteriovenous shunts which are formed because of the uh, in the tumor, doing TACE will also reduce that, sir. And basically, you are optimizing the patient further, sir.
Yeah. Swaroop, 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 are you listening?
Sir, actually, I'm in another discussion, sir. I'll join in after some time, sir.
Yeah, okay. I just wanted to know your views on TACE. You come back when you are ready.
Yes. Yes.
Okay, right. Now, so portal vein embolization, TACE and TARE. TARE, any ideas on TARE?
Uh, Yes, sir. Like I have covered it individually, sir. Like first I was
Okay,
doing
okay.
dissection, then TACE and
Yeah,
TARE is there, sir,
okay. Yeah,
ahead.
okay. Yeah, go on with resections now then.
Yes, sir. So in terms of surgical resection, we'll also look at the hepatic reserve and volumetry,
Yeah.
wherein liver volumetry can be measured using the CT, MR, or scintigraphy, and like there are various formulas available wherein you will be calculating the functional liver remnant, and that is the ratio which is measured between the volumetrically measured FLR and the total liver volume.
Yeah,
And
which is
through
better? Which is better for volumetry?
uh, so like it depends.
No, it
So
doesn't
like
depend. MR
so
scan
I'm
is
not
better.
sure, sir.
MR scan is better for volumetry. It will also give you a lot of information about see, we are talking about, hepatocellular carcinoma which appear de novo, or hepatocellular carcinomas which appear, which come out on the background of a hepatic, cirrhosis, either due to hepatitis B or hepatitis C, or due to alcoholic cirrhosis, or even non-alcoholic, focal liver disease, fatty liver disease, which usually causes cryptogenic cirrhosis. So if there is background cirrhosis and then you have a tumor, again, because of the MR, you can do the elastography also with MR. You can combine that with the ultrasonic elastography also, and you do volumetry, and you can find out the functional reserve of the liver and how much you can resect. So that is the advantage of the MR. CT will give you other informations like the vascularity of the tumor and all these things, and invasion of any major hepatic vein or portal vein and all those information is better gleaned by CT scan, especially the triphasic variant. And then the MR will give you the information about the functional reserve of the liver and what portion of the liver can be resected, all this information. Okay. Any questions so far?
No, sir.
All of you are following? Only Professor Ballal is asking questions. None of you are asking any questions.
Sir, one question, sir. Actually, for measuring something like now they are using like standard total liver volume, which is the CT's value with the formula value. Then they are taking the ratio, which is taking this, which is like a standard now they are taking. Sir.
No, I understood, but the thing is, if you ask the radiologist, they will give you the values, all the values that you want with an MR scan better than the CT scan.
Yes, sir. Yes. Okay.
Because CT cannot, though CT will tell you about cirrhosis and all that, the suppleness of the liver, how much infiltration, how much of fibrosis, and all this information is better with MR scan.
Yes, sir.
So ultimately, it's not just the volume. That is why I use the word functional liver volume.
Yes, sir. Yes.
Okay, right. So there you will have to see when you are in a regular hepatocellular carcinoma, that is that which appears on a de novo liver, which the rest of the liver is healthy. In such patients, it is not so critical as it is in patients who have background cirrhosis. There you may have to do both, MR and CT, and also you have to remember there can be multifocal hepatocellular carcinomas in these patients who have background cirrhosis. So you have to be aware of that also.
Yes, sir.
Okay.
Sir, I've just put, can I interrupt for a minute, sir?
Yes, sir. Yes, sir.
I've just put one article screenshot on our group, Sagar group. Preoperative test for resectable hepatocellulars. It's a 2014 article. Let them read through when they are this one, because it's not downloading for me.
Yeah, okay.
I put a screenshot. Sometime, yeah, when you guys are free, you can read it.
Yes, sir. Thank you. Thank you so much, sir.
Right, sir.
Continue, ma.
Yes, sir. So we'll be checking the hepatic reserve and volumetry. One more assessment tool which is available is not frequently done, but you use the clearance of indocyanine green at 15 minutes, which will as a defining criterion so that you can select patients for resection, and you basically see the clearance and patient if it is more than 15 minutes, that is when you consider that there is it's not like maybe the liver function reserve is not adequate enough for the patient to withstand the further resection process. Then there are various clinical scoring systems also available, which includes your Child-Pugh classification and MELT score and the albumin bilirubin score recently, which will further help in categorizing patients so that you can choose patients for resection. To summarize, you look at the tumor size, the location, the extrahepatic mets, the underlying liver function test. Furthermore, you will also look at the you can use the Child-Pugh scoring system wherein patients falling in the category A with no cirrhosis and a potentially resectable single lesion less than 2 centimeters with a normal portal pressure, which can be measured using the wedge hepatic pressure gradient. And in these patients, first you can consider optimizing the patients by doing portal vein embolization and plus minus stays, especially if you're considering a right hepatic lobectomy. And once these are done, you can go for a complete resection if all of these criteria are met. Furthermore, for complete resection, there are various resection techniques which are available. In this, we will have firstly an anatomic resection and a non-anatomic resection. When anatomic resection is basically you're following the planes of the liver segment, which are the Conrad segments. So as to this is ideal in cases where there is a hepatocellular carcinoma in a non-cirrhotic background. Because in such cases you can dissect up to 2/3 of the liver like the parenchyma can be safely removed. And the other resection type would be the non-anatomic resection, which is usually for cirrhotic patients, because here resection is generally limited to less than 25% of the functional parenchyma. Otherwise, these patients are very prone to decompensation and developing liver failure post-surgery. Furthermore, you have various hepatic resections, which was proposed by the Brisbane International Biliary Association, which has classified hepatectomy into right and left hemihepatectomy, trisectionectomy, and even lobectomy.
What are they called? First order, second order, and
like it is based on the segments.
First order, second order, and third order. What are they? Anybody? No, I think it's homework for you guys. You need to know what they are.
Yes.
Because I can't keep on giving you all the information. Has anyone read any articles about comparison between anatomic resection and non-anatomic resection for disease-free survival and overall survival? See, we keep Dr. Lakshman, me, all of you we keep telling you, you can't just read textbooks and come for these kind of classes. It has to be embellished by reading, the alternate and additional literature, up-to-date literature for up to 2024, 2023, 24. In the latest journals to look at the differences between the survival for anatomic and non-anatomic resections. See, there are many papers and even the meta-analysis, and also this one. And what is the other one called? Systematic review. All of them suggest that there is very little statistical difference between anatomic and non-anatomic resections as far as the overall survival and disease-free survival is concerned. But for hepatocellular, this one, the intrahepatic cholangiocarcinomas, the Chinese study has shown that there is significant difference, advantage for anatomic resections as opposed to non-anatomic resection. Probably because the tumor would have spread along the bile duct, and hence, following a proper anatomic resection would be much more, useful as an oncologic exercise as opposed to just resecting, giving a 1 centimeter margin, which is what they do with the non-anatomic resections. So there is a difference there. But as far as hepatocellular carcinoma is concerned, there is no difference, maybe partially, but not statistically significant difference in the disease-free and overall survival rates between anatomic and non-anatomic resection. Vinod, tell me about what is anatomic, what do you understand by anatomic resection and non-anatomic resection?
Anatomical resection basically this basing on the Conrad's segmental resection, sir. Non-anatomical is basing something like basing on the tumor, we will remove the clear as much as possible clearance, sir.
So, but what do you actually do with anatomic resections?
We'll remove the particular bile ducts, for that segment, whatever the artery, portal vein, and bile duct will be ligated, sir, in that.
So you have to follow the anatomic, for example, segment 4 all the segment 4 duct, the segment 4, the arterial, that is the hepatic artery branch, the portal vein branch, and the hepatic vein branch. All of them have to be ligated,
Right.
and then you remove it. So that is called the anatomic resection. So there are various, the first order is, I'll tell you, first order is to do a left hepatectomy or a right hepatectomy, or classically called as right hemihepatectomy or a left hemihepatectomy. It is not the what appears as the left lobe. It is the left hemihepatectomy will be segments 1, 2, 3, 4. So that is left hemihepatectomy, and segments 5, 6, 7, 8 will be right hemihepatectomy. Then you have extended right or trisegmentectomy. Left will be 2, 3, 4, and 5 and 8. The right extended right hemihepatectomy will be 5, 6, 7, 8, and 4, and sometimes including the caudate lobe as well. So the advantage, what are the perceived advantages of doing a hepatectomy, Vinod?
Sir, chances of recurrence will be low, sir.
Yeah, I told you, the recurrence rates are not different. The advantage would be that because the liver has the ability to regenerate,
Yes,
so
sir.
it will regenerate and the liver functions will be, so you are possibly achieving oncologic clearance. Whether it will translate into local recurrence and overall survival, disease-free survival, is still debatable. But because you have the ability, the liver has the ability to regenerate, over a period of 3 to 6 months, the liver will grow to about 75 to 80% of its original size. So thereby giving the patient a good, hepatic reserve and function.
Yes, sir.
So I think, as einass has said, I think all of you have to remember whenever there is a de novo hepatocellular carcinoma, that is carcinoma arising in a normal liver where there is no disease background, I think it is safe to go for an anatomic resection. In patients who have cirrhosis of liver, you have to be careful, as I said, because due to this field theory, the cirrhosis is there in the entire liver. So there is nothing that prevents tumor that has appeared in one area to appear in another area also. So you should be very careful. You should be very careful. You can even use intraoperative, either laparoscopic or intraoperative ultrasound to detect any tumor in the liver segment that you are going to leave behind, and then you do a non-anatomic resection, leaving behind definitely more than 25% of the liver. I think even 45% is probably what is expected of it. So that much liver you have to leave behind. Otherwise, as einass said, they will go into rapid hepatic decompensation in the post-operative period, and they may go into encephalopathy and die. So you have to be extremely careful. So you can use all the investigative modalities in your armamentarium to try and ensure that you are resecting about 1 centimeter margin and all around the tumor, and then ensure that there are no other foci of tumor in the liver. Shrikant, welcome. Any questions, any suggestions or clarifications?
Sorry, I came late, so the course I not able to follow. Yes, urgent
Okay.
I came late.
Okay, einass, continue.
5 minutes back I did.
Yes, sir.
Talk about all these resection terminologies.
Yes, sir. So firstly, there is a right hepatectomy and left hepatectomy, wherein
So that is the first order, ma. This is the first order, what you have written there. And then the segments will be second order. And then the third order will be, mix and match.
Okay. Yes.
Okay, yeah.
Yes. So when we talk about right hemi, that is segment 5, 6, 7, and 8. on the left side you have 2, 3, and 4. Trisectionectomy is basically extended right or extended left hepatectomy, wherein you have basically your 4, 5, 6, 7, and 8 will be there if on the right side, and the left side will have 2, 3, 4, 5, and 8. Then furthermore, you can have the segmentectomy or sectionectomy, wherein the left side will be 2 and 3, and right will be 6 and 7, and only only when the caudate lobe is involved, that will be caudate lobectomy or segmentectomy.
See, all of you, the first order will be the first two, the second order will be the next two, and the third order will be the last three. Okay, so if anyone asks you that question, it's first order, second order, and third order resections. So this is very important because the radiologist will give you all the information that you want before you can consider doing these things. Okay, carry on, ma'am.
Yes, sir. And the last thing is the predictors of after resection. You will have predictors for survival, which will include the tumor size and the tumor number, presence of microsatellites, vascular invasion, the severity of cirrhosis, and the alpha fetoprotein levels. Wherein the tumor size of less than 2 centimeter has a significantly high survival rate. The tumor number, the survival for a single nodule will be ranging between 50 to 60%. But if there are 3 or more than 3 nodules, then it will drop to as much as between 20 to 30%. And further, there will be vascular invasion also. So, the survival there is a median survival of around 90 months for without invasion, and as low as 8 to 12 months if there is microvascular invasion. And in terms of alpha fetoprotein levels, you measure the ratio of alpha fetoprotein levels to the tumor volume. And if it is more than 1.5, then that is it is considered to be an indicator of risk of recurrence. And it is associated with up to 70% risk of recurrence rate or appearance of any new lesions. Then, yes, sir. This is like a dissected specimen in HCC, wherein the arrow mark is showing the tumor, and the resected specimen with the tumor and the underlying nodular cirrhotic liver. Then going to locoregional therapy. The locoregional therapy will include TACE and TARE, wherein TACE
Just a minute,
Yes,
just
sir.
a minute, ma'am.
Yes,
Have
sir.
all of you understood the principle of non-anatomic resection?
Yeah.
Hello, Sania,
Yes, sir. Yes.
tell us how you do non-anatomic resection.
Sir,
It's very difficult to understand in the first attempt to read again and then doubt to have to get clarification. Sorry. Liver resections are difficult to understand, so you have to repeatedly read, discuss, and then in doubt you should discuss with ask Dr. Ravishankar.
So tell me what you understand by non-anatomic resection.
so it non-anatomical liver resection is where the resection is done, where you don't follow the segments of the liver. So because either the liver is cirrhotic, where you don't get the planes for anatomical resection, or if the tumor is very small, where you don't have to remove the entire segment.
No,
That's
you will
when
get the planes. You will get the planes. So what you have to understand is you use what is called as a finger fracture technique, where you
Yes,
keep
sir.
fracturing, the vessels will not tear. So then you ligate them, or you can use the KUSA.
Hormone.
What is KUSA?
Yeah.
Or you can use the you can use this one, the ultrasonic resection shears, or you can use the what do you call them, the bipolar. So there are very good electric resources now. So you can use the ultracession, what is it called? Ultracession is I'm just not getting the name of what we commonly use,
Harmonics, sir.
Harmonic.
Harmonics.
So harmonic scalpel, that is called, ultracession is the name of the thing. Anyway, so you use that, or you use the QSA, or you use the bipolar, and basically you keep on find the you can put a margin around 1 centimeter clearance all round, and then you keep resecting. And if you encounter a vessel, you can suture ligate them and keep going and finish it. And after that, you make sure that you achieve proper hemostasis before coming out.
Yes.
So that is the principle of non-anatomic resection. And
Yes.
anatomic resections will be much more straightforward. Again, there are two methods. One is the usual routine, what is going at the hepatoduodenal ligament, identifying all the vessels, and then tracing them up to the the area that you want to resect. Or the other one is called the Glisonian technique, where you go to the hepatic plate and then identify the vessels there, that is at more nearer the porta. So the advantage of that is there is less chance of injuring the major vessels if you do it there, because you are more likely to encounter the vessels that are directly supplying the segment in question or the segments in question. So that is called the Glisonian dissection. So you can use either of them, whichever you are comfortable with, and then do that. So anatomic resection. So non-anatomic resection is basically you have to put a margin around and then keep resecting, and either use whichever energy source you are comfortable with. QSA is also used, or you can use harmonic scalpel, you can use the ligashore and whatever. And then if there is a major vessel that you encounter, you ligate them. And at the end of resection, again look at the liver surface wherever there is bleeding, so you can take care of the bleeding, and that completes the resection. So that is the difference between anatomic and non-anatomic resection. So read up about it. If there are any doubts, we'll think answer them in the next class. Okay, carry on.
On table, how to make you are giving 1 centimeter margin? On table, how do you decide whether you are giving 1 centimeter margin?
So tumor in the you can
palpating the tumor, is it?
You can measure with a tape. You give a 1 centimeter.
Palpating the edge of the tumor.
From the edge of the tumor. See, it may be more difficult if there are multiple tumors, but you will have to. That is why with multiple tumors, the prognosis becomes poorer, because especially in background cirrhosis, you may not be able to resect that much of the liver. Einass, carry on.
Yes, sir. Yes, sir. So
Science of inoperability ಎಲ್ಲ ಆಯ್ತಾ?
ಅದೆಲ್ಲ ಹೇಳಿದ್ದಾರೆ both class ಅಲ್ಲಿ ಹೇಳಿದ್ದಾರೆ.
Yes, sir. So going to TACE, that is chemoembolization. So indications are those, like for example, if there is a candidate being considered for transplant, as a bridging therapy, we can do TACE. It can also be done to downstage a disease so as to enable resection later on. And it is considered in patients who have a large intrahepatic tumor burden, that is multiple tumors of size less than 5 centimeter, or multiple tumors with one of them being of size more than 5 centimeter. And to assure that there is no vascular invasion. The contraindications to TACE include if there is a patient like having severe underlying comorbidities like heart failure, renal failure, or leukopenia. They are if there is a presence of malignant ascites, poor baseline function, patients with end-stage cirrhosis, like if the child classification is falling in the category of C. patients with who have already developed decompensatory features like encephalopathy, and for if there is any main portal vein thrombosis, and even patients who have some features of biliary obstruction with a bilirubin greater than 3 milligram. And these are one of the few contraindications for undergoing TACE.
What about metastatic disease? Even metastatic disease is a contraindication unless you are doing TACE to reduce pain or something.
Yes, sir. Like palliative care, we can consider.
Yeah, for palliation of pain.
Okay. Yes, sir.
Yeah.
And relative contraindications are a few these lab parameters, like other parameters like LDH levels of more than 425, your aspartate AST levels more than 100, and if patients have untreated esophageal varices at high risk of bleeding, and if there's a prior history of TIPS procedure. So these are the conditions, relative contraindications. The complications to TACE will, the most common adverse effect which occurs in about 60 to 80% is post-embolization syndrome, which consists of varying degrees of right upper quadrant pain. They can also present with fatigue, fever, and in terms of lab parameters, there could be a transient elevation of AST, ALT, and bilirubin levels. Usually, these symptoms are self-limiting and resolve within 3 to 4 days.
I have to interrupt here.
Yes, sir.
This elevation of AST, ALT, which you have mentioned, right? In
Yes, sir.
reality, when you're doing it in somebody with hepatic failure, I mean liver cancer who is not operable, their LFT will already be bad. Their liver reserve will be low. A little bit of elevation will be quite serious. They may quickly go into fulminant failures also. And in reality, the tolerability of TACE is not very good in Indian population, especially in people who are elderly. And there have been people who did not make it out of the procedure also. So it's not as easy as people portray it to be, especially in somebody who is not very fit on fail. Somebody may have background cirrhosis. Somebody may have very poor performance due to comorbidities. So we should be very careful during patient selection for TACE. In a way, TARE is somewhat more easier to do, but it is a lot more expensive. Please proceed.
What do they use in TARE, Swaroop?
Sir, in the TARE, we are using this Yttrium 90 radiation and radioisotope eluting beads. So they are more localized in their action. The systemic toxicities are less because whatever we infuse into the 5FU kind of thing, fluoropyrimidine, floxuridine, and all those things in TACE, they may cause some amount of permanent damage to the liver, remaining liver which is not affected, and can also lead to the systemic circulation called cytopenias and all those issues. In TARE, it does not happen.
Do you use it along with lipoidol? You use 5FU or cisplatin or doxorubicin? What do they use now?
For TACE, we usually use floxuridine. It's also a prodrug of 5FU only.
5FU.
It's an antimetabolite. It's an antimetabolite related to 5FU though.
Okay. So
basically, we want a drug which is metabolized in liver, doesn't go to the system.
As simple as it is. Yeah.
In the well-selected patient, it may be easy, but in reality, to get yes. So basically, we want somebody who is non-metabolized. So it's a difficult task.
Yeah.
Somebody who's metastatic but well preserved. So it's not easy to find such patients usually.
Correct.
And if you have a liver, I mean lymph nodal metastasis and everything, then TACE will not anyways work.
That's what metastatic disease you do. If at all you are using TACE, it's only to symptomatic relief of pain or something like that.
Yes.
Yeah. Okay. Carry on, ma. What is the technique?
So it varies, sir. Like there is injection of a chemotherapeutic agent into the hepatic artery, and you may or may not use lipodol, which is lipodol is basically an oily contrast agent that is used so that you promote the the chemotherapy retention, but it does not contribute to arterial occlusion. So basically, you are using it for chemo lipodylation is what you are doing. Further, you use chemotherapy agents which can be used to include epirubicin, cisplatin, and doxorubicin. And now you also have drug-eluting beads which are available, and which can be used over conventional TACE. And there are a few, like in countries wherein doxorubicin eluting beads and even irinotecan eluting beads have been available to use in the TACE procedure. So you start by catheterizing the hepatic artery, and after you identify the tumor feeding vessel, and furthermore, like supposedly if a patient has a solitary tumor, the catheter can be placed into a second order or a third order branch of the artery. And if there are multiple tumors in one lobe, then lobar chemoembolization may be considered. And however, this is associated with a higher risk of ischemia and post-embolization syndrome. And further, you can use doxorubicin 60 mg with lipodolol, and there can be other like cisplatin can be used between a range of 50 to 100 mg, and even mitomycin of 10 mg can be mixed in 10 ml of water soluble contrast and emulsified along with lipodolol, and it can be used together. In addition to this, we have to also make sure that we are administrating broad spectrum antibiotics before the procedure is taken up. And yes, sir, and prophylaxis against nausea and vomiting, appropriate antiemetics and narcotic analgesia should also be considered. In addition, you can also have TACE, which can be used along with local ablation, and TACE split radiotherapy, which can be used. But this is usually reserved for patients who have associated portal vein thrombus, and but also they have a unilateral portal blood flow which is preserved. And furthermore, you will keep on monitoring the lesion size 1 month apart, and then accordingly the retreatment is decided in TACE procedure.
Okay.
Yes, sir.
Continue.
Yes, sir. Herein it can be seen like this is you have the tumor here, followed by like the TACE procedure wherein embolization is happening, after which a repeat scan after 1 month, which is showing that there is a regression in the tumor enhancement, which can be seen post TACE procedure. Going to the radioembolization, in here you are using Iterrium 90 or resin microspheres, so that you're inducing tumor necrosis, and that is how you're inducing tumor necrosis. The indications are somewhat similar to what we do for TACE patients. And in terms of contraindication, you will see patients who have clinically overt hepatic encephalopathy, biliary obstruction, and patients who are belonging to Child-Pugh C classification, Child-Pugh C scoring. And again, this can also be used as a measure of palliation or in the bridging therapy as well. The complications associated with tear will include post-embolization syndrome, but the severity will be less in comparison to TACE. Hepatic dysfunction may happen because of the radioactivity to the surrounding liver parenchyma, and this can contribute to liver failure. And other than that, there can be again transient hyperbilirubinemia which may be seen. Further, so in the same procedure as that of TACE is followed, and you will be using yttrium labeled glass or resin microspheres to do the procedure. Then you also see the treatment response to loco-regional therapy, wherein you will be for assessment, you will be using the LIRADS treatment response algorithm to see how is the loco-regional therapy affecting the patient. In contrast enhanced MRI, after loco-regional treatment will be done, and then you'll have to see whether the enhancing tumor it meets the viability criteria. That is, the viability criteria includes like it should nodular, mass-like, or irregular tissue in or along with the treated lesion with an arterial phase contrast enhancement. So in that case, that will fall in the LRTR viable group if you have these additional features which are seen. That means that it might require another setting or another attempt at loco-regional therapy. And similarly, you will also keep on observing for complete lack of contrast enhancement and post-treatment enhancement patterns will be looked at. And this will help in monitoring the response to the loco-regional therapy. You also have ablative therapy, which is available, which will include radio frequency ablation, ethanol ablation, cryoablation, and microwave ablation. Further, going to systemic therapy. In case of systemic therapy, there are various drugs and available which will which are used in systemic therapy. In this, firstly, you'll have
I think
so
just a minute. We'll
Yes,
ask
sir.
if Sarup is there. Just
No,
give
this
us
is
a-
adjuvant treatment or neoadjuvant or palliative systemic therapy.
So I think Sarup, if you are free, just
Yes,
give
I'll
us a
quickly
short,
give the
yeah,
outline of what this is.
yeah.
These are used when surgery is not feasible. This is neither adjuvant nor anything. You use it either in metastatic disease or in recurrent disease where surgery is no more feasible. And other options like local radiation therapy, local SBRT or taste are all not feasible. There is some doubt as to which is. Some people say immunotherapy is better, some people say taste is better. But as a medical oncologist, I'm more biased towards immunotherapy and chemotherapy. The use of atezolizumab and bevacizumab is a combination of immunotherapy, that is PD-L1 inhibitor, namely atezolizumab, and bevacizumab is a VEGF inhibitor. One is anti-angiogenic drug, one is immunotherapy drug. This combination, to be honest, it's an all or none kind of phenomenon. 20% of the people will get long-term disease control, spanning many, many years. And the remaining will do okay for maybe 1 or 2 years. That's how it is. And atezolizumab is one option. We have other combinations also which we can use. Instead of atezolizumab, we can use pembrolizumab along with lenvatinib. It's a oral form of bevacizumab. That is also we use very often. Then we use nivolumab in a low dose in people who can't afford, along with lenvatinib. That's also giving very good responses. We have seen people staying well for 3 years, 4 years easily. Then we go to the second thing which is mentioned, tremelimumab plus durvalumab. That's basically dual checkpoint inhibitor, wherein using a CTLA4 inhibitor along with a PD-1 inhibitor. The problem with this approach is very toxic. You should be using it only in well-preserved young patients who can tolerate the toxicities. Otherwise, we generally don't use this approach. Then the third option, lenvatinib, sorafenib, they're also quite decent options. So they may not make the disease fully go away, but they can make the patient live well for quite some time. Especially with lenvatinib, the side effects are very minimal, whereas with sorafenib, you have quite some bad amount of side effects like thrombosis, embolism, all those things. So unlike in the past few years, these days even metastatic liver cancer, when treated appropriately, they easily do well on an average for 2 to 3 years, and sometimes many more years than that, sometimes less than that.
Okay, I think that is fairly so. Basically, I think if resectional treatment is possible, it is feasible, and patient is fit for it, go for resectional treatment. If the patient is, fits the criteria for transplant, and transplantation is available and affordable. So you go for transplantation is one. Otherwise,
even
you
in
can
recurrent
go-
disease, we should think about this. Even in some solitary recurrence, we should still think about resection, especially single liver mets, all those things.
Yeah. And then you can think about the tears and tear both as bridging therapy and also as treatment options in patients whom surgery is not, patients are not fit for that. And then you can also consider systemic chemotherapy. Also, there is the radiotherapy, that is PDRT. Swaroop?
SBRT.
SBRT, yeah.
Yes, since the local therapies like RFA and all cannot be used in every part of the liver. There is something called the heat sink effect. When we use RFA, if there are nearby blood vessels which are flowing, that will take away the heat generated by the radio frequency, and there will be no effect, especially near the big vessels of the liver. In those situations, we cannot use RFA. Sometimes very deep, we cannot put so many needles to do RFA. So SBRT is one good method where you're using focused beams of radiation to give a very high dose of radiation and ablate the disease.
Yeah. Okay. So I think that in brief concludes the management of primary hepatocellular carcinoma. Any doubts?
What is the role of fiber knife?
Cyber knife is
That's a form of delivering SBRT. One of the tools which we can use to deliver SBRT.
SBRT.
It's a robotic linear accelerator, which is very good at delivering SBRT. There are other methods, but cyber knife is the pinnacle in terms of safety and efficacy when doing SBRT.
Any doubts? Okay. Rajesh Ballard sir, your comments on the class?
No, sir, I wanted to, because you preempted. I wanted to ask him, what is the cyber knife, sir? The answer was given already, sir.
Yeah.
It's okay, sir.
So, Sanya, what is your take home message, and also about the class? How did you find the class was?
So the class was very good in detail about everything. Like Srikanth sir said, I have to go back and read and then maybe listen to the class again to get a better this thing. So a lot of information was there.
All these anatomical lobes, all those things should make a chart, paste it on this thing wall, and you have to go through daily.
Yes,
difficult to remember because I have got low IQ. I don't know.
Okay. So, Srikanth, I think, sir, Rajesh Ballard, sir, what did you think of the class? Srikanth probably
This is the
cannot
main
comment.
part. I am one sincere request, 10 minutes or 5 minutes before the class begins, please put up on the WhatsApp.
Yes. Okay. Okay.
The
Ballard,
sincere
sir.
request to the residents.
I relearned a lot, sir. Very truthfully, I relearned a lot.
Thank you.
I've been missing a lot of classes in the middle, but today I did, sir.
Thank you so much. So this one is, I think einass did a fantastic job. She's actually, what I admire most about her is the slides are good, and she doesn't put too much information on the slide, and she has the ability to explain a lot of things. I think bullet points and then explanation. So I think most of you have to do that. I think that is the best way of delivering a lecture. So the bullet points are there, but then you have to be able to elaborate on that, which I think einass probably understood it well, and she did well. I think by and large this was a good class, and I think einass has to be congratulated for a lot of information and a lot of proper explanation. Good night.
Good night, sir.
Thank you for all of you for attending.
Good night, sir. Thank you, sir.
Good night, sir.
Good night.